So good afternoon, everybody. My name is Bart Chwalisz. I'm a physician over at Mass General and Massachusetts Eye and Ear Infirmary, specializing in neurology, neuro-ophthalmology, and neuroinflammatory disorders. And so I'm welcoming you to this, I believe, third installment of a series that is brought to you by the Sumaira Foundation for NMO, and made possible by a patient education grant from Viela Bio. And the title of today's seminar is Living with Immune Suppression. And I will say that this whole series is inspired, or made necessary, I guess, by the current COVID pandemic. But the talk today is not necessarily specifically geared towards dealing with COVID, although I imagine there might be questions about that. My colleague, Dr. Michael Levy, a couple of weeks ago had a beautiful talk about COVID and how it relates to neuromyelitis optica. If you have those specific questions, I also encourage you to watch his talk. So today's talk is about living with immune suppression. And I hope it will have some value beyond the current pandemic. And so what I want to talk about for a few minutes is what do we mean by immunosuppression, how does it affect people, and what you can do as a patient who is immune suppressed to live well with immunosuppression. And after that, we should have ample time for questions as well. All right, so let's talk a little bit about immune suppression. And so, why do we need it? Well, we think that NMO and related disorders on the neuromyelitis optica spectrum, including MOG disease and other ones, are disorders where the immune system is overactive in a way. They're disorders of autoimmunity. So we all have an immune system. We all need an immune system. The purpose of immune system is primarily twofold. One is to fight germs, bacteria, viruses, parasites, and so on. And then also the second function is to fight cancer. And that's what the immune system does. And normally there are a number of checks and balances in the immune system that prevent the immune system from attacking the body itself, the body of a person itself. Unfortunately, in certain situations, those checks and balances don't work, and people develop a break in the immune system where a part of the immune system does create an attack on the body. And that's the situation I believe happens in neuromyelitis optica, where there's an antibody, the aquaporin 4 antibody, that can bind actually to parts of the body, and in certain circumstances trigger an attack on those parts, mostly of the central nervous system, the optic nerve in the spinal cord, and other such areas of the central nervous system. So we think of NMO as a disorder where there's an overactive immune system, and a large part of what we do as doctors taking care of people with NMO is to suppress the immune system. In an acute attack, a lot of these anti-inflammatory and immunosuppressive medicines that we use are primarily to just decrease inflammation. And then after a person is out of the acute phase, we enter the preventive phase, and we use longer-term medicines where we're trying to keep the immune system suppressed enough that attacks don't occur anymore. Now, of course, the problem with that is that we're also weakening the body's ability to have the immune system do the job that it's supposed to do, which is, again, to fight germs and to fight cancer. So we have to have a fine balance. We're always sort of walking on this tightrope, where we don't want too much immune suppression. We don't want to put people at risk for having complications from the immune suppression, on the one hand, and on the other hand, we need to control the autoimmune disorder, in this case NMO. So it's a fine balance. Okay. We don't want to overdo it. We don't want to underdo it. We have to get it just right. Sometimes it's a process of trial and error. We use a number of different medicines. Some of the medicines, like steroids, for instance, are very broad spectrum. They just generally squash the immune system down and are very good for controlling inflammation very quickly. Other medicines that we use, like rituximab, for instance, are much, much more focused, much more specific. They only very, specifically target a part of the immune system and don't have as much of an effect on the immune system overall. All right, so let's talk a little bit about what we can do to do this well, what we can do as doctors, and what you can do as patients to get this balance right, and to make sure that we're not overdoing and we're not underdoing it, and we're giving you the best possible quality of life. And so I would say the first thing that we should do when it comes to starting immune suppression is actually prepare for it. Ideally, we have time. We don't always have time, but ideally we have some time to set the immunosuppression up and to do some studies beforehand, do some preparatory work beforehand, so that it's smooth sailing when you actually start the medicine. Now, unfortunately, NMO is a very unpredictable disorder. The attacks come unannounced, they come quickly, they come hard. And so we don't always have the time to prepare that we would like. But in an ideal situation, we'd want to get some blood labs beforehand, before we even start anything. And we'd want to do some preventive work in terms of getting people on the right vaccinations to keep them safe. So what am I talking about here? Well, one of the problems with immune suppression is that sometimes there could be an infectious disease sitting in the body in a hidden sort of way that the patient is even completely unaware of sometimes, that could re-emerge, that could come out when the immune suppression is started. And I'm talking about, sort of big chronic diseases like hepatitis B or tuberculosis. Okay, so those are things that we should ideally test for before we start any immune suppression. Certainly before you start something like rituximab, it's mandatory to check for hepatitis B, tuberculosis. I usually also check for hepatitis C, because we don't want to start a medicine like rituximab and then a few months later somebody is going into liver failure because we didn't know they had hepatitis B. And they could have gotten it years ago and was sitting there quietly. The immune system was suppressing it until we weakened the immune system and that hepatitis B re-emerged. I also always check people for HIV, and I do it for everybody. I don't, not necessarily that I suspect that people have HIV or have a higher risk than average for HIV. It's simply that I need to know that if I'm going to weaken somebody's immune system, I need to know if they already have a weakened immune system to begin with, because that's going to change how I approach things. In fact, I also even check for some of the things that people should have been vaccinated for. Okay, so I usually like to check for measles and mumps immunity. Okay, now most of us have been vaccinated against measles and mumps, and for most people who are born after 1980, 80 or so, people should have measles and mumps immunity, although it can go down as people get older. And people who were born before 1957 or so, they just naturally all got measles and mumps as children, so they should be immune on that basis. But people who were born between the 1950s and the 1980s, they were born at a time when some states mandated measles vaccinations, others didn't. Some just did one, others did multiple shots. So it was not consistent across the United States. And so some people may have good immunity, others don't. And it could, as I said, it can go down with age anyway. And if you've been following the news, we still get outbreaks of measles and mumps that happen from time to time, and we don't want somebody to get it. Those are easily preventable illnesses. And also the vaccine, the measles mumps vaccine, is a live vaccine. Okay, what I mean by that is some vaccines just use parts of a virus or parts of a bacterium, or a dead virus, dead bacterium, and you give a vaccine, and there's no infection that can happen from that. But some vaccines are live vaccines. If we give them to somebody, people can actually get infected from it. And so the measles, mumps, rubella vaccine is a live vaccine. We really shouldn't be giving it to somebody who's immunosuppressed afterwards. So we want to give it beforehand if we can. So again, the theme here is if you have time before you start immune suppression, you want to check for chronic illnesses. You want to check that people are immune to vaccine-preventable illnesses. I would say that especially applies to people who have also have traveled to places outside the United States. So if people have been to the tropics, there's certain parasites like strongyloides and Chagas disease that we want to check for that might not apply to the average person. And so if you're going to your doctor and saying, and having this conversation about getting immune suppressed, and you have spent more than 3 months living in South America or in another tropical area, do let the doctor know. There might be other things that they want to check for that they wouldn't normally think of because it doesn't apply to most people in the United States. And again, those parasites can sit inside the body, completely silent, suppressed by the immune system until we weaken the immune system, and then they can sort of rear their ugly head again. So we want to know beforehand, ideally. And then, I like to get all those vaccines done before starting immune suppression. Not only the ones that we just talked about, measles, mumps, hepatitis B if people have risk factors, which means multiple sex partners or sharing needles or blood transfusions and those sort of things. Also, I generally want everybody to get a pneumonia shot, the Pneumovax. There's actually 2 different variants, and I tell people to get both, and I tell people to get them 8 weeks apart. Those are not live vaccines, so when you could do those still after you get immune suppressed, but they take better if you do it beforehand. So again, if you can get all your vaccinations done, the pneumonia vaccine and those sort of things beforehand, that will be ideal. I tell everybody they need to get a flu shot. That doesn't have to be before. That can be after they're immune suppressed as well. And also, I tell everybody that their family members should get a flu shot as well. Okay. So why am I so concerned about these respiratory illnesses? Well, I was concerned about this before COVID. I've always been meticulous about this in my own practice because those are the sort of things that I worry about. I know I can control the NMO, and I know most people with NMO can do okay. Not everybody. Sometimes it's hard, but for most people, we can get it under good control. But I worry that now, after I've stabilized people, that they could come down with one of these respiratory illnesses and get sick. Okay, so I try to prevent the flu, try to prevent pneumonia. Whooping cough is another one. Okay, that's a respiratory illness that is preventable. Most of us have gotten the whooping cough vaccine as part of a tetanus shot. Okay, it's a tetanus, diphtheria, and whooping cough, or pertussis. But whooping cough immunity goes down as people get older. The CDC recommends that every adult should get 1 booster whooping cough as an adult at just one time in their life with a tetanus vaccine, and the tetanus should be every 10 years. So every 10 years you should have a tetanus diphtheria, and one of those should be a tetanus diphtheria plus pertussis or plus whooping cough. Okay. Again, if you can beforehand, but also that is not a live vaccine, that can be done later. Okay. So that's the whole planning. So ideally, if I have time, usually try to do a whole session, a clinical session, just on planning, getting ready for immune suppression before we even do it, and we try to get all these things started, get all these lab tests, get all these vaccines started before we even started. All right, but sometimes we don't have a luxury, and then we have to deal with the fact that now you're immune suppressed. What can you do to keep yourself safe, to live well, whilst immune suppressed? So going back to what I said in the beginning, we try to split the immune suppression into the 2 parts. There's the acute treatment that we do for an acute attack, of NMO, if it's an optic neuritis or transverse myelitis, whatever it is. And then afterwards, there's the second part, which is the preventive part. So the acute treatments typically that we use for NMO are steroids, IV, often also oral steroids, plasmapheresis, so people call it blood exchange, and sometimes IVIG, intravenous immunoglobulin. The biggest one in terms of affecting your immune system are the steroids. And some people just get 3 days of IV, but some people are on a longer steroid taper. We don't try to use steroids for too long because the side effects from the steroids build up over time. Okay, so even if you tolerate steroids initially, at some point you will get side effects. Well, it's almost unavoidable. We still use steroids because they act fast. They act for almost any kind of inflammation. So we can shoot first, we can ask questions later, give people steroids, get the inflammation down, and then we can fine-tune it later. So they're good like that, but that they will have side effects, and almost any organ system that you can think of is going to be affected by the steroids. So we talked about the immune system part. That is a big part. So people who are on steroids are immune suppressed. The more steroids they're on, the more immunosuppressed they are. Oftentimes we use 20 milligrams of prednisone or so as a cutoff, as where we really worry about people being immune suppressed. In fact, if you're on that dose for more than a couple of weeks, usually we'll put you on a protective antibiotic called trimethoprim sulfamethoxazole or cotrimoxazole, also known by its brand name Bactrim, and that's supposed to prevent a particular nasty lung infection. So the more steroids you're on, the more immunosuppressed you are, and we try to keep you safe. But also, almost any other organ system will be affected. Starting with the mind, a lot of people get irritable, have trouble sleeping. A lot of people's blood pressure can go up, blood sugars can go up. Steroids thin the bones, meaning they can cause osteoporosis. They can thin the muscles. They can thin the skin. They can cause cataracts in the eyes. They can raise the eye pressure, which is glaucoma. So any organ system, you name it. Our stomach ulcers, I should mention, can be affected by steroids. So what can we do? Well, the first thing is, use as little steroid as possible for as short as possible. And then, we try to mitigate the immune suppression part by giving you the Bactrim and giving you all the vaccinations that we can. We try to mitigate the part about the stomach ulcers. If you're having heartburn, sometimes the doctor will put you on a heartburn kind of medicine, a proton pump inhibitor, things like omeprazole. And the part about the osteoporosis, the bone thinning, we definitely recommend that anybody who's on steroids for longer needs to be at least on vitamin D. D as in dog. And then if they don't take dairy, I'd also want them to take a calcium supplement as well. So those are all important things to think about. And then you need to work with your primary care doctor if you're on steroids. You need to work with them, tell them that you're on steroids. They may have to adjust your blood pressure medicines if you're on blood pressure medicines. If you're not on any blood pressure medicines, still a good idea to have a blood pressure cuff at home and check the blood pressure once a day when you're on steroids. You want to do it the same time every day. Like let's say in the morning before you even get out of bed, check your blood pressure every day and make sure it's in a normal range. If you have diabetes or pre-diabetes, definitely your sugars will need to be checked carefully during the time when you're on steroids. That's a big deal. If you have any history of glaucoma or were considered a glaucoma suspect, you need to see your eye doctor regularly to have your eye pressure checked as well, and be monitored for things like cataracts. Anybody who's on steroids for a long time should see their eye doctor generally at least once a year, if not twice a year. And if they have a history of glaucoma or are at risk for glaucoma more frequently than that. And so those are sort of some things that are very important for people who are on steroids. As far as other immune suppressants are concerned, that is going to depend very much what immune suppressant it is. A number of them are going to require some particular labs. that need to be monitored. So if people are on mycophenolate, which is Cellcept, or azathioprine, which is Imuran, then those medicines require like every 3 months or so that the blood counts and liver function need to be checked, just as a safety precaution. And so it depends. You have to work with your specialist then on which labs are required, but probably some labs will be required. And then, you know, as far as just generally living with immune suppression, most of the time when people have reached a stable state, you know, their disease is controlled, they're on an immunosuppressant, whatever it is, you know, a stable dose of azathioprine or a stable dose of rituximab, we want people to live a normal life as much as possible. And we want you to use common sense and to be careful. You know, what are some situations where you need to be careful? Well, currently we're dealing with a pandemic. You know, anybody who's immunosuppressed is probably at greater risk than the average person. We don't know that for sure yet, but we believe it's probably the case. So stay at home. Avoid unnecessary travel right now. If you go out, wear a mask, wear gloves. You know, if you go to the grocery store, avoid touching your face. Clean your hands frequently. Avoid having people inside your house. So those are precautions you can take right now. And generally speaking, you know, you want to be a little more careful when it comes to activities that other people maybe don't have to think about as much. For instance, if you're a gardener, you know, you like to be outside in your garden, maybe you want to wear thick gardening gloves, because that rose prick that for another person wouldn't be such a big deal, that can carry an infection that can spread and can be a bigger deal for you. If you have any particular unusual hobbies, or even just, you know, things that maybe are more common, like, I don't know, let's say horseback riding, if you know, shovel manure or something like that, or you work with other animals, you work with hay. Maybe you even want to have a consultation with an infectious disease specialist to talk about what are particular risks in that sort of situation that, you know, the average person maybe doesn't have. If you're going to travel outside the United States and you're immune suppressed, I would highly recommend a consultation with a travel clinic. Talk about what are some precautions you can take, additional vaccinations, additional things. So, you know, all these things you need to maybe, you know, just be a little more conscious of, a little bit more aware of than you otherwise would have been. And if you're able to do that, most of the time you will be able to have a fairly normal life with your immune suppression. It's just sort of using common sense is I think, the most important thing. You can still get most vaccines when you're immune suppressed, except for the live vaccines, which again are things like measles, mumps, rubella. The yellow fever vaccine, if you travel, is a live vaccine. There are 2 chickenpox zoster vaccines, so herpes zoster or shingles vaccines, that are, one of them is a live vaccine, that's the older one. The newer one is not. It's not a live vaccine. But it does, you know, it can stimulate the immune system. So it is one where I recommend if your NMO or your autoimmune disease is super active, you may want to hold off on that one until it's calmed down a little bit. But then you should be able to do it. And if you're, you know, a special case here, if you're on eculizumab, brand name Soliris, then you need a meningococcal vaccine, and that should also be something that actually is done beforehand. So you still need to get all those vaccines. That certainly should be getting the flu shot every year. Your family member should be getting a flu shot every year if you're immune suppressed. So those are the things that I really wanted to mention beforehand. I think I wanted to leave some time here for questions. And you know, I think what I'm going to do is maybe read some of these questions off and see what people are saying. All right. So here's a question. That's from Sumaira. Dr. Chwalisz, it sounds like you are quite meticulous and order a comprehensive set of labs and vaccines for immune-suppressed patients. Is this common practice for other neurologists? Is this a work a patient should be asking for if their doctors don't volunteer it? So that's a very good question. I certainly as I said, I've always, even before this COVID pandemic, I've always worried about my patients getting infections. You know, when you do this for long enough, as a doctor, you will see some patients who unfortunately get infectious complications. So, um, is it common practice? Well, um, it probably depends a little bit on each doctor probably has their own little set of things that they do. Um, it's become much more common for NMO and similar diseases to be actually managed by neuroimmunologists. There's more and more neuroimmunology clinics, specialty clinics, and academic programs that are focused on treating patients with autoimmune disorders like multiple sclerosis, neuromyelitis optica, MOG disease, and many other ones. And so those of us who consider ourselves neuroimmunology specialists or experts are probably a little more meticulous. Okay, if you feel like your doctor is not having this conversation, it doesn't hurt to remind them. Okay, I'm a strong believer in patients being advocates for themselves. If you're if you're if you think you have special concerns about it, you should always bring them up. Um, if you remember after the appointment, send your doctor a message or call them up. It is worth talking about these sort of things because you want to keep yourself safe. This is your health. This is the most important thing that you have. We want you to have an optimal quality of life, even though you're immune suppressed. So the next question, so that's a tough one. For someone already on rituximab, when should they get their flu shot vis-a-vis next rituximab infusion? For instance, if my next infusion is December 1st, should I get it November 30th, November 15th? Rituximab is, I mentioned earlier, is a fairly commonly used medicine. It's approved in many countries to treat neuromyelitis optica. It's not technically FDA approved, but we use it very commonly in the United States. It's not so much something we do during acute attack. It is one of those longer-term medicines that we start afterwards to prevent more attacks from happening. And it is, for many patients, a very effective medicine. It doesn't suppress the immune system as a whole. It is much more targeted. It takes out a part of the immune system called the B cells that are making antibodies and also helping other parts of the immune system work, such as the T cells. Rituximab is typically given as an IV infusion, a lot of times as a loading dose, one infusion and another infusion 2 weeks later, or sometimes one every week for 4 weeks. And after that, oftentimes it's given every 6 weeks on average. Sometimes people get it more frequently, every 4 months. I should say, sorry, 6 months. 6 months, not 6 weeks. 6 months. And then some people get it more frequently, maybe every 4 months. Some people get it less frequently, and sometimes we can check whether the B cells are really suppressed in the blood to see when the person needs the next infusion. So what I'm saying is some people are on a pretty strict schedule, but sometimes there's a little bit of wiggle room. Okay. And so, a lot of times that effect of the rituximab lasts many months, and if you get it a few weeks earlier, a few weeks later, it's not such a big deal. As far as when the flu shot, also there usually is a lot of flexibility when exactly you could get your flu shot. You want to usually get it in fall. It probably will be a little less effective if it's given immediately, shortly before or shortly afterwards. So you probably want to space it out by a few weeks after rituximab to get the ideal effect. Next question. What blood work is necessary every 6 months before rituximab infusions? Due to COVID-19, can those labs be skipped if blood work has been stable over many years on rituximab? So what blood work is needed? Well, the most important blood work is needed before you even start with rituximab, which again are those chronic infections that some people can have silently in their body, like hepatitis B and tuberculosis. That is usually a one-time thing, unless people have more risk of exposure. That's a one-time thing before you even start it. That's sort of the most important thing. Some infusion centers require that the hepatitis B keeps being rechecked. Okay, and that it again depends on risk. Um, and then the other lab that we do often is to check how effective a rituximab is, meaning whether the B cells are truly suppressed. Not all doctors do this. It's sort of an optional practice. Some people who are treating NMO will say, well, we need to focus on whether you're having attacks or not. If you're not having attacks, we don't need to check the blood labs. So we go more by the clinical picture. Other people really like to have those blood labs and like to see when those B cells go up again, and they like to have them use that as guidance for the next rituximab dose. Those typically, you know, that will be done sort of shortly before the next, about a week or so before the next rituximab. Sometimes people get the blood draw at the same time as the infusion, and then you can sort of compare those. Can that be skipped? Well, I would talk to your doctor about whether that potentially can be skipped. We certainly generally are now saying that anything that is elective, anything that is optional, if it can be deferred until the pandemic is under better control. And that probably includes routine blood labs that are not critical. Some blood labs are critical. If you're on azathioprine, if you're on mycophenolate, you do need to get your liver functions and your blood counts checked. But maybe they can even be drawn from home. Some places have nurses that can come to the home and draw it at home. Maybe you don't even need to go to a lab. And the other things, MRI scans similarly, maybe they can be deferred if it's just a routine MRI, not an acute attack. Maybe that can be deferred until the pandemic is under better control. Next question here. Any special precautions you would recommend for college students living at school? That's a really good question. So college students living out off campus, whether it's with their parents or not with their parents, probably not, okay? They should still have the same precautions. You're going to be, anytime you're in college, you're exposed to a lot of people. You should be getting the flu shot and those sort of things. If you're living in a dormitory, you're a college freshman in dorm. Same with a military recruit in a barrack or in a dorm. You probably do want to take additional precautions, and specifically, you want to think about whether you want to get a meningococcal vaccine. So that prevents a severe form of bacterial meningitis. That again, the same vaccine is mandatory if you're going to go on eculizumab, which is Soliris, and maybe there's something that would be recommended as well for somebody who's going to live in sort of tight quarters. If traveling internationally, should I bring prednisone, and if what dosage? Another very good question. So the answer is probably yes. I think that if you're at risk for having recurrent attacks on the central nervous system, recurrent optic neuritis, recurrent transverse myelitis, or other kinds of NMO attacks, it is good to have some prednisone available to take quickly. But it is something that I would discuss with your doctor for sure, because realistically, the dosages of prednisone that we use to control an attack of NMO are very high, very substantial, which is why we typically start with IV steroids. Can you do it orally? Yes, you can. There's some good trials that show you can use oral steroids instead of IV steroids, but you're really talking about very high dosages. You're really talking about 25 prednisone tablets or something like that. So it's not practical to necessarily carry hundreds of prednisone tablets with you. But to get you through that first day until you can get to a hospital, not unreasonable. It is maybe something that you could discuss with your doctor. All right, next question. I have a grandbaby due in July. When she gets live immunizations, do I need to stay away from the baby? I'm on rituximab. So, a couple of issues here. So one is rituximab. How much does it sort of suppress the immune system? You said it's much, much more targeted. It really doesn't weaken the immune system in a big way. You're not necessarily susceptible to more infections, like cold and such in the average person. Anybody exposed to little children will get more of those things anyway. But in terms of being on rituximab, not necessarily. Um, and I think the risk of getting, measles or mumps or chickenpox or something like that from a baby from a vaccine is very, very small. So I don't think that is a big concern. Okay. All right, next question. I'm worried I may need Plex. Will Plex take my immune system down further? What precautions should I take when doing Plex? I'm thinking of wearing a full plastic suit and police helmet. Is that over the top? And I presume that the person who's writing this is worried about the full plastic suit and the police helmet currently in the COVID pandemic. I don't know that we necessarily will be getting these sorts of worried questions if we weren't dealing with a pandemic. But let's talk briefly about Plex. So Plex is not a medicine. Plex is, a way of filtering and removing blood. So it's sort of a blood wash, a cleaning of the blood. And the idea is to remove harmful antibodies. We know that in NMO, the critical player is the aquaporin 4 antibody. Without the aquaporin 4 antibody, you don't really get NMO. And then in addition to the actual aquaporin 4 antibody, there are other messenger proteins that are in the blood, called cytokines that are essentially like immune system hormones that are also, that can be removed as well to some extent. So all those, harmful substances, those evil humors, as I like to call them sometimes, are removed by the plasmapheresis. And then, we remove like a blood volume or blood volume and a half, and then we give people back just sort of basically neutral fluids. They don't have as much in terms of the antibodies. When we're doing that, we're removing the harmful antibody. We may also be decreasing sort of some of the other antibodies. Now, most of them are replenished very quickly. Okay, so Plex has a very short-term effect. Can you get more infections during a time when you get Plex? Yes, people are at risk of bacterial blood infections, sepsis, and those sort of things during the Plex. They're also at risk of other things like blood clots. So Plex is certainly a big deal. You only do Plex when you really have to, but the effect lasts for only a few weeks at best. Okay, and then the immune system comes up, and actually, if you're using Plex to control NMO or MOG disease or any of those related conditions, you're not going to have a long-lasting effect just from using Plex. Plex will acutely help the problem. It will not keep you safe for more than a few weeks at best. Plex, of course, has to be done either in a hospital or in a specialized infusion center or a facility run by a blood bank to do this. And so right now, we want you to avoid any unnecessary exposure to the healthcare system. So if you don't have to have a procedure, whether it's Plex or another procedure, don't have it. Now, anybody where Plex is considered probably does have to have it. Plex is not something we do just because. It is something that usually is considered very necessary. And so probably if your doctor says you need to have Plex, you probably do need to have it, but have it be there for the shortest amount of time. When you come, stay in your car until you can. Don't sit around in the waiting room. Have a procedure done. Get out as quickly as you can. In the waiting room, wear a mask, wear gloves, sit away from other people. So take all sort of precautions, social distancing and hygiene precautions while you're having the procedure. A full plastic suit and a police helmet I understand. I have 100% sympathy for the idea here. Probably not what you need to do. You primarily need to have a mask. Healthcare workers that are exposed to aerosols or air particles that have virus also need to wear goggles. but you shouldn't be around other people where aerosol is being generated. So primarily we're talking about a mask. Here's another question. Hi doctor, have you ever heard of a patient who contracted NMOSD, which is neuromyelitis optica spectrum disorders, as a result of papillary thyroid carcinoma? This is my case. The tumor was removed and I'm on rituximab. However, my doctors are unsure about how long to treat with rituximab due to a lack of data on cases similar to mine. Yes, I think you hit a nail on the head. This is a difficult situation. Just to explain, we think of neuromyelitis optica as an autoimmune condition where there's an overactive immune system. That's why there's this harmful aquaporin 4 antibody. And in other patients with a related condition have other antibodies like MOG. And most of the time, this autoimmune disorder just happens. There isn't anything you did in particular to make this happen to you. You didn't do anything wrong. It just happens, and we have to deal with it. Sometimes this overactive immune system condition happens because it's actually stimulated. It's triggered by something. So we do get situations where people have an immune system that's actually responding to a cancer. We call that situation a paraneoplastic disease. So it's, neoplasm is the medical term for cancer, and it's paraneoplastic because it sort of has a side effect from a cancer. So the immune system, I said, it has two functions: fight germ, fight cancer. Okay, so somebody could be having cancer, and it doesn't have to be a big cancer. It could be a teeny cancer that's sitting somewhere, and the immune system is fighting it. It may even be fighting it very effectively and suppressing it, keeping it small. It could be a hidden cancer. But because this immune system is constantly revved up and is constantly fighting this cancer, sometimes there can be a collateral damage, and the immune system gets overstimulated, and antibodies produced by the immune system can cross-react with other parts of the body. So that's called a paraneoplastic disorder. Is NMO a paraneoplastic disorder? Well, in most cases, it's not. Okay, the vast majority of patients with NMO do not have a hidden cancer. And we do not generally go searching for a hidden cancer when somebody gets diagnosed with NMO. That said, there may be an occasional situation where NMO does occur as a paraneoplastic disease. So there are some case reports of that in the literature. I have encountered that in my clinical practice and maybe once before as well. So there are some experts who recommend that NMO patients who get diagnosed over the age of 50 maybe should get a screen for cancer, and like a scan of the body and those sort of things, as well as the age-appropriate cancer screening that all of us should have anyway, which is a mammogram for women over the age of 50, a colonoscopy every 10 years, a cervical pap smear, and those sort of things which are standard. But in addition to the standard cancer screening to have a whole body scan to look for cancer, if you get diagnosed with NMO over the age of 50. When that happens, though, how long should you be treated for? So is your situation totally unique? No, it's not totally unique. There are other people like you who have probably paraneoplastic NMOSD. But how long should you be treated for? How long should you be on rituximab for after the cancer is removed? That is a very difficult question, and I don't feel entirely comfortable sort of making a judgment without knowing, the full sort of details of a clinical case, and it may be that it just has to be, a conversation that you keep having with your doctors about when the right time is, because as you're saying, there aren't a lot of data on cases like yours. Next question. I have anti-glycine relapsing transverse myelitis, even rarer. Will you ever study this antibody in America? It's studied here in the UK. So very good question. So, there's been an evolution over time in the recognition of different antibodies. In fact, there's been an evolution over time in how we understand neuromyelitis optica and NMOSD. It was described in the 19th century. It was really put forward by a French physician by the name of De Vic. So that's why we still sometimes call it De Vic's disease. And at the time, De Vic thought you had to have an optic neuritis and a spinal cord inflammation at the same time. Turns out it doesn't have to be at the same time. Then for the longest time, people thought it was a variant of multiple sclerosis. Until, Dr. Lennon at the Mayo Clinic found the aquaporin 4 antibody, and clinically, clinicians at the Mayo Clinic were able to define the criteria that we use with modifications to diagnose NMO. And then, we defined NMO both clinically and by the presence of the aquaporin 4 antibody. Then, a few years later, people realized there is a second antibody in some patients who have seronegative NMOSD, and that's the MOG antibody. And so now we talk about this whole new disease, MOG antibody disorder or MOG encephalomyelitis, which is similar but a little bit different to NMO, and also different to multiple sclerosis. Neither one of them we think is really a version of multiple sclerosis. And so we have, could do a whole talk on MOG disease. But even if you put all the patients with aquaporin 4 NMOSD and MOG antibody disease to the side, there's still a number of patients who have NMO spectrum disorders that either we don't have an antibody at all, they're completely seronegative. Maybe there is an antibody, but we're not able to find it yet. Hopefully in a few years we'll have an answer for you. Or they have other more unusual antibodies. And so, the glycine antibodies are one of the newer, actually paraneoplastic antibodies. There's another one called the CRIM5, CRMP5 or CV2 antibody, which is also a paraneoplastic antibody. Some of them occur with cancer, some of them occur without cancer. So those are very special cases. Do we study it? Yes, we certainly have individual patients who have these less common antibodies, and we're very interested in studying them. The Mayo Clinic as well probably has the biggest program for studying these kind of antibody syndromes. All right, some of the people I live with don't realize how sensitive my body is. Is there something particular I should be telling them to make them understand how sensitive my body is to various diseases? So that's an excellent point. You're not an island, and you're certainly not an island when you're immune suppressed, because everybody who's around you is going to share all their germs with you. So I think it is important to have conversations. Okay, it is important to when you're comfortable, when you're ready for it, to sit your family down, sit your friends down, and say, I have this condition. Because of this condition, I am immune suppressed. I need you to be aware of this. I need you to work with me and help me, to be at less risk. And so like I said earlier, you certainly need to, for instance, encourage people around you to get the flu shot. Same with that once in adult life whooping cough vaccine. I think people around you should be getting that as well. If you can decrease the risk around you by keeping everybody vaccinated as much as possible, you decrease your own risk. And also, it's only fair if people who love you and care for you know that you're immunosuppressed, that maybe during the time when they're sick, they stay away from you. I mean, right now, that's sort of obvious with the COVID pandemic, but I honestly think that we're, even after the COVID pandemic is over, we probably will have to change the way we think about transmitting germs to each other. And one of those things is going to be, if you're sick, stay at home. As much as you can. Don't go to work, don't go to school, don't expose other people, and don't visit that friend or family member of yours who is immune suppressed, because they might have a much more severe illness than you do. Okay, for you it might be a mild illness. For them it could be life-threatening. So I think knowledge is power, And I think that having that conversation with people is very important. My screen is frozen. Anyone having this problem? Well, I'm not, so I'm not able to help you with that. I'm sorry. Next question. I had a DPT vaccine in 1984 and had a reaction. So that's the diphtheria, pertussis or whooping cough, and tetanus vaccine. The redness and swelling at the site and a high fever. I've been on Rituximab since 2006. Should I be getting a DPT and how often? And so that is a very good question. So what to do in somebody who has had a reaction to a vaccine beforehand, and now they're thinking, well, maybe they should have a vaccine. I told you we normally want a tetanus shot every 10 years. Another one, maybe if you got exposed to, if you have a dirty wound or something like that, where you are at risk of tetanus. And one of those should be with a whooping cough. But what if you've had a reaction? Well, there's different kinds of reactions. There's having a sort of some local swelling that's relatively normal after a vaccine. Having a fever, well, that's just the immune system reacting to the vaccine. That's not necessarily something that should prevent you from having a vaccine again. If you have an immunological reaction to a vaccine, that's a different story. Those are much less common. Those are rare. Okay, but in the 1970s, there was a flu vaccine. It triggered a condition called Guillain-Barré syndrome. Occasionally, we meet somebody who's had that problem in the past. And very, very occasionally, somebody with NMO will have an attack shortly after they get a vaccine. So that can happen as well. So I think there you really need to have sort of a conversation on a case-by-case basis with your doctor. As far as your particular situation with the DPT vaccine, I think you probably would be able to have it if you want to have a consultation with an infectious disease doctor or an allergist about what your risk is actually of having a severe reaction. It wouldn't be wrong, it would certainly you'll be able to be more informed, and maybe it would take some of the worry away. But I suspect that the experts will tell you that you should be able to have it. Next question. If a patient has tested positive for COVID-19 and has recovered completely, would they be able to donate their plasma to other NMO patients to help build up their immunity? So you may have heard about this treatment in the news. So it's a treatment of convalescent plasma. So COVID-19 is this pandemic that's caused by the SARS-CoV-2 virus. And we believe that most people who get it once and survive it are then immune and are not going to get it a second time, as far as we know. This is a new disease. There are still things that are being explored about it. But as far as we know, once you've had it, you shouldn't get it a second time. So there's this idea now that the blood of the people who are recovered should have protective antibodies to SARS-CoV-2, the COVID-19 virus. Maybe we can give it to really sick people. And so there are several trials that I'm aware of in the United States right now that are specifically exploring this. So you're gonna hear, I promise you, if that is positive, you're gonna hear about it all over the news. So that really works. We're gonna know about it. There's good reason to think that it might work. It has been tried in other countries. We just need better trials to do it. Would you be able to donate your plasma specifically to other NMO patients to help build up their immunity? That's a little more tricky. I don't know, just like I don't know of a way that you can, if you're giving blood, that you can say my blood should specifically go to patients with a particular disease. I don't know that there's a way that you can specifically give it to people with a particular condition, or keep it safe for your friends and family. Probably you would donate it, and then doctors would use it according to the protocols. Next question. Do you routinely measure B-cell counts when using B-cell depleters such as Rituximab? Any thoughts on the upcoming novel therapies for NMOs D and the ability or risk of mounting an immune response to newly administered vaccinations? So do I routinely use it? I personally do not necessarily routinely do it, but some of my colleagues routinely do it. Okay, so there's a little bit of variability. Um, what's the reasoning for doing it? Well, the reasoning for doing it is it tells you whether rituximab is effective at decreasing the B cells in the blood. Is that the same as getting rid of all the B cells? It's not. It's effective at decreasing the B cells in the blood, but there will still be B cells in other parts of the body. They will still be outside of the bloodstream, in the liver, in the lungs, around the optic nerves, and so there will be stored B cells, which is why, your immune system is not wiped out on this. Okay, so can somebody have completely depleted B cells and still have an NMO attack? Absolutely. Some people have fully effective, B cell depletion by rituximab, and it doesn't control their NMO completely. So, and maybe giving the rituximab more frequently, maybe 3 or 4 months, will control the disease. Okay, so it may look on the blood labs like it should be working, but maybe that person does need it more frequently because there's always extra store of B cells that are outside the bloodstream. And then any thoughts on the upcoming novel therapies for NMOSD? Well, yeah, the biggest one that's already FDA approved is eculizumab or Soliris, which inhibits a part of the immune system called the complement system. Complement is needed as part of the NMO attack to make the attack happen. So it's not just the aquaporin 4 antibody. Complement comes in and completes the attack and makes it a more severe attack. So that one's already FDA approved. As I said, you need that meningococcal vaccine beforehand. You should be able to mount most normal vaccine responses. Inebilizumab, which is another very similar medicine to rituximab, and there's another medicine called sartrilizumab, which inhibits a compound immune system called IL-6, which probably also is not it's very selective. It probably doesn't generally decrease your immune system's ability to mount a response very much. Next question. What specific labs well on CellCept? So CellCept is the brand name for the generic mycophenolate mofetil. And so that's a more general immune system depletion medicine. It works similar to azathioprine, which is Imuran, in that it interferes metabolically with the white blood cells' ability to develop, and so you have fewer white blood cells and lymphocytes. So a lot of the time you can monitor that on mycophenolate, what lymphocyte is. A lot of times doctors will target a particular lymphocyte level. And then we usually like to check blood counts, the complete blood count, CBC, and liver functions as well. But again, talk to your specialist or your primary care doctor, whoever is taking over the monitoring for your mycophenolate. All right, I'm being told that there's time for 2 more questions, and then after that, I would encourage people to still ask questions online, and I'll answer 2 more right now. What is the highest B cell count you've seen an NMO patient have before relapsing? So I think that's a question again about the B cell monitoring that we do. Maybe I'm misunderstanding the question, but the question is, maybe what's the lowest? And as I said, it can be fully suppressed. It may less than 1%. And it is possible to have an attack. One more question here. Does rituximab impact on NMOSD patients' fertility? So good question. We didn't talk as much about pregnancy considerations and breastfeeding considerations. It probably is a very good topic for another talk, but rituximab has been linked to some problems like lower birth weight. It probably doesn't affect your fertility as much as, if possible, it would be ideal not to be on it while you get pregnant. Now, many patients, unfortunately, don't have a choice, and it is safe to do during pregnancy for many people. Other things like methotrexate or mycophenolate, which is CellCept that we talked about before, have a much bigger effect in terms of causing birth defects. So some of the medicines really are a big problem. All right, so I think that officially, we're out of time. We're out of questions. And I sincerely, there's a number of more questions, so I apologize. But this time definitely flew by. Thank you for listening in. Thank you for your interest, and please be safe, be careful, use common sense.